السلام عليكم.
السلام ورحمة الله وبركاته.
احنا طبعا هنتكلم النهارده زي ما منذر قال عن الجزء الثاني من الصوديوم ديس اوردرز. احنا اتكلمنا المره اللي فاتت عن الهايبونتريميا، المره دي هنتكلم عن الهايبرنتريميا. بما ان في اوفرلابس ما بين الهايبونتريميا والهايبرنتريميا، ف يعني غالبا هنبتدي ببعض فيو سلايدز كده من المحاضرة اللي فاتت عشان نفكر الناس بالكومن ارياز اللي هي ريليتد للفسيولوجي والفيزيكال بروبرتيز بتاعت الصوديوم ديس اوردرز يعني. هو زي ما اتكلمنا المرة اللي فاتت عن الهايبونتريميا وأهمية الهايبونتريميا، ف يعني هنشوف نفس الأهمية بالنسبة هايبرنتريميا. طبعا الهايبونتريميا احنا قلنا اللي هو السيرم صوديوم less than 135. الهايبرنتريميا السيرم صوديوم above 145. وبما ان هي اولا it's common اللي هو الصوديوم disorders, it's common in hospitalized patient, and sometimes it's community established, and we meet such patients in the emergency room. It's complicated to understand, complicated to manage. عشان كده احنا هنبتدي الموضوع من اوله، من اول الفسيولوجي and physical properties related to sodium disorders. زي ما شفنا في الهايبونتريميا usually it is associated with multiple comorbid conditions. يعني usually we don't have sodium disorders in healthy patients, but usually it comes with comorbid conditions, and usually the comorbid conditions are serious conditions. So whenever we find a patient with sodium disorders, whether hyponatremia or hypernatremia, in addition to attention to correction, we have to look for the comorbid conditions probably which is underlying the disorders. يعني in itself, whether it's hyponatremia or hypernatremia, it is associated with a lot of complications which might lead to mortality, morbidity, but usually it denotes an underlying medical problem that we have to look for and search for. So again, I think you remember this slide from before about the osmosis. We'll pass mostly on this slide today because it is repeated. We know the concept of osmosis when we have two compartments separated by semi-permeable membrane, and semi-permeable membrane is defined as a membrane which allows the passage of water and doesn't allow the passage of solutes. When we have two compartments with different solute concentration, water moves from the compartment with low solute concentration to the compartment of high solute concentration. It's a fact we studied maybe in the secondary or preparatory schools. This slide also, it's repeated, but just a reminder. We are going to talk about, whenever sodium is concerned, we are going to talk about osmolality. And what is osmolality? Osmolality is the number of osmoles per kilogram of solvent. Number of osmoles, number of particles in a kilogram of solvent, and the plasma osmolality, which is normally around 275 to 285. It's measured, but it can be calculated as well. And we are going to know that sometimes we need to have both the measured osmolarity and calculated osmolarity. And this is the formula how we are calculating the plasma osmolarity from the lab tests we have. 2 multiplied by sodium. Why 2 multiplied by sodium? Because sodium is usually associated with the chloride anion. And both of them, when dissociated, it exerts the same osmotic forces, plus glucose. If it's in millimole, we'll just add it. But if it's in milligram per deciliter, we are going to divide by 18 plus urea. If it is in millimole, will be added as it is. But if it is in milligram per deciliter, we are going to divide by 2.8. And there is a difference between osmolality and tonicity. Osmolality is osmotic pressure created by any dissolved particles in a solution. But the tonicity, it's the effective osmolality. And what is the difference between osmolality and tonicity? We have particles, particles which cannot cross the semi-permeable membrane, which is in our case is a cell membrane, like sodium and chloride. But urea can cross it's lipid soluble, so it can cross the cell membrane freely, and hence it cannot create an effective osmotic pressure. So it's not participating much to the tonicity. We know that glucose in the normal range of the blood glucose, which is around 100, 120, it doesn't exert much osmotic pressure, but when the glucose is high, sometimes like 500, 600, 700, it exerts high osmotic pressure. And I'm going to remind you with this Edelman equation, which states that the plasma sodium equals the total exchangeable sodium plus total exchangeable potassium divided by total body water. And here we can notice that the plasma sodium can be affected by total exchangeable sodium and total exchangeable potassium, and is affected by total body water as well. And I think, as mentioned, in hyponatremia and hypernatremia as well, we are going to state that most of the sodium disorders are a water balance disorder rather than total body sodium disorders. It's disturbed relation between the total body water and total body sodium. And in the majority of cases, it is related to disturbance in total body water. So we can say with confidence enough that whenever we see either hyponatremia or hypernatremia, we have to think of disturbance of total body water rather than thinking of disturbance in total body sodium. Again, just a reminder that the body weight of the human body is 60% water in male and 50% water in females. And this is divided into 2 big compartments, which is the intracellular fluid, and a smaller compartment, which is the extracellular fluid. And this extracellular fluid is further subdivided into interstitial compartment and intravascular compartment. The 2 compartments of the extracellular fluid are freely exchangeable. So whatever water and solutes here are exchangeable. I mean small solutes, not large solutes, are exchangeable between the intravascular and interstitial compartments through the capillary pores. But the physiology of the membrane, which is dividing the intracellular compartment from the extracellular compartment, is different, because This is the cell membrane, so it acts as semi-permeable membrane, so it allows free passage of water across a concentration gradient, but it doesn't allow the passage of solutes like sodium, chloride, potassium, except under certain conditions and with energy-operated pumps. Here we have to remember also that when we are talking about the osmolarity and osmotic pressure, usually it's in equilibrium. So whenever we have change in the osmolarity of the extracellular fluid, there will be equilibration after some time. Suppose we have hypoosmolality in the extracellular fluid, so water is going to move from the extracellular compartment into the intracellular compartment until the osmolarity are equilibrated. The second fact that we have to remember here, that sodium is the major contributor of the extracellular osmolarity, but potassium is the major contributor of the intracellular osmolarity. And the third fact, that usually the fluid gain or fluid loss is primarily from the extracellular compartment. It's not from the intracellular compartment, because we are gaining fluids either by oral intake or by intravenous fluids. It's going initially to the extracellular compartment, and then by osmotic gradient, it moves to the intracellular compartment. So this means that the sodium, which is the major extracellular cation, is a major force or major solute which is controlling the content of water in the human body. This is also a repeated slide from the last lecture, and just to remind you that all of us inhales, we don't have too much changes in sodium concentration in the body or serum sodium, because it's tightly regulated by both fluid intake or by water intake, water excretion by the kidneys, as well as regulation of the total body sodium by the kidneys as well. So now we will talk again, because this is so important, about osmoregulation. طبعا يعني عشان افكركم بالاسموريجيليشن بحاجه بلدي شويه. طبعا احنا كلنا في شم النسيم بناكل فسيخ ورنجه وملوحه وكده، ودي طبعا it contains high sodium load. Whenever we take any of these salty food which is contains sodium load, it is going to be absorbed, and when it is absorbed, it goes to the extracellular compartment. So it increases the plasma osmolality, because the amount of solutes relative to the water is increased. So the body has a defense mechanism against this increased osmolarity and increased sodium load. So this increased osmolarity is going to stimulate the osmoreceptors, which is present in the hypothalamus. And the effector of this stimulus is going to be in two directions. It is going to stimulate the thirst. We are going to feel thirsty, so we are going to drink water. In the meantime, the hypothalamus synthesize antidiuretic hormone, which is stored in the posterior pituitary. So it is going to be stimulated. The release of ADH is going to be stimulated, which will work on the collecting duct of the kidney to reabsorb free water. And the combination of reabsorption of free water from the kidney and the thirst sensation leading to water intake is going to restore the osmolarity back to normal. This is what happens normally in healthy patient. I just want to remind you that if we look at the volume regulation, we'll not go deeply through this because it's not as important as in hyponatremia, but we have to notice that we have an area of overlap here between the osmoregulation and volume regulation as well. So let's go to the deeply into the hypernatremia pathway. As I explained by the example of ملوحة وفسيخ ورنجة, when we take these salty foods, this is going to lead to increased extracellular fluid osmolality, and this is going to stimulate the thirst, leading to water intake, and leading to ADH or vasopressor release, which is going to increase renal water reabsorption. Both mechanisms are going to conserve water in the extracellular compartment, which is going to restore the extracellular osmolarity back to normal. This is the normal pathway or normal mechanism. So this means whenever we have hypernatremia, so we have a problem in such mechanism. So we have to remember this pathway when you are dealing with the causes of hypernatremia. So what is the pathophysiology of hypernatremia? So hypernatremia, if we are going to take the pathway I mentioned and adapt it to the causes, maybe the subject is taking inadequate water, or maybe there is water loss which exceeding the sodium loss. So finally, there is net water deficit in such cases, and examples of this, if there is excessive insensible loss from the skin and lungs and GIT, and this is going to happen, for example, in marathon runners in hot weather, for example, who are producing big amounts of sweat, which is essentially water with little sodium, in patients who are hyperventilating with a lot of water loss through the lungs, or patients who are taking, or subjects who are taking osmotic agents leading to diarrhea, or gastroenteritis cases, for example, or maybe renal losses if a patient is taking diuretics, especially loop diuretics, or in cases of diabetes insipidus, and we are going to talk about diabetes insipidus later on in details. Maybe this subject is having abnormal thirst, so the mechanism for thirst is abnormal, and we are going to mention what is the causes of abnormal thirst later on. In very few cases, it's related to sodium gain. It's high load of sodium gain. But again, we have to remember that most of the cases of hypernatremia is related to net water deficit. Sodium gain, usually it happens in most of the cases are iatrogenic. Whenever we give excessive amounts of high sodium load solutions, the best example is sodium bicarbonate by some enthusiastic people who are giving sodium bicarbonate for some indications. The normal saline we are using is 0.9%. This is an isoosmotic or little hyper osmotic fluid, but the sodium bicarbonate is 8.4 sodium, which is around 10 times sodium content of the normal saline. So it's a high sodium load. And hypertonic fluids, sometimes we use like 3% sodium chloride in certain cases. If you are not taking care about the sodium load, it might lead to hypernatremia as well. And in few cases, it's related to impaired renal function, like in some patients with chronic kidney disease. So Now let's take each title of this pathophysiological factors which leads to hypernatremia. The first title is inadequate water intake. How can a person or patient gets inadequate water intake? So the reason is this person or this patient doesn't have access to water. And the examples of this are infants, for example. Infants are not requesting, if they are thirsty, are not requesting water. If are not taking about care about the drinking water or noticing when they are thirsty to give them water, so there will be net water deficit and consequently hypernatremia. And some patients, they have hypodipsia, I mean there is obtundation of the thirst mechanism, and this is common in elderly patients. And frequently we face such patients in the emergency departments when they are alone, they are neglected, they are in home, I mean in اللي هي بيوت المسنين وكده. ف they have blunted thirst mechanism, so they are not drinking enough amount of water. So sometimes we face such patients in the emergency department with hypernatremia, which is just related to lack of adequate amount of drinking water. And this is the commonest part we face, I mean, from my specialty, which is a patient who is unconscious or intubated in the ICU. So patients who are unconscious or intubated in the ICU, they don't have thirst mechanisms, they cannot request water. So if the ICU physician is not considering this factor and adding enough free water to the patient, there is hypernatremia in such patients as well. And this is very common actually in the ICU. What about the second title, which is water loss in excess of sodium? What situations leads to water loss in excess of sodium? The biggest example is diabetes insipidus, and as we know, we have two types of diabetes insipidus: central diabetes insipidus, which is related to either lack of secretion of antidiuretic hormone due to disease or destruction of hypothalamo-pituitary axis, or sometimes it's due to mutation in the genes expressing the ADH hormone. The second type is the nephrogenic diabetes insipidus. In such cases, there is excretion of, or there is secretion of antidiuretic hormone, but the kidney is not responding to this antidiuretic hormone, leading to diabetes insipidus. So the second reason for loss of excess water, loss of water in excess of sodium is osmotic diarrhea. Actually, myself, I didn't see this because it is a bit far from my practice. But the third is the loop diuretics. I mean, we see this patient a lot if we are giving the loop diuretics in excess. So the loop diuretics is known to cause excretion of sodium and water, but usually the water loss is more than the sodium loss. So finally, there is net water deficit when we are using big doses of loop diuretics as well. The fourth one is the osmotic diuretics. Osmotic diuretics, we have the most famous osmotic diuretic we use is the mannitol. And we see a lot of such patients when we have an enthusiastic neurosurgeon or neurologist who are giving big doses of mannitol in patients with increased intracranial pressure, and we are not giving much attention to the huge amount of water which is excreted by when we give osmotic diuretics. So there is a huge amount of water lost. Actually, osmotic diuretics, it leads to both sodium and water loss, but actually the water loss is too much relative to the sodium loss when you are using osmotic diuretics. The fourth title is abnormal thirst. What is abnormal thirst? We mentioned the hypodiphthia, which is very common in elderly patients. And if we have patients with hypothalamic lesions, hypothalamic tumors, and pituitary tumors as well, because the ADH is synthesized in the hypothalamus and stored in the posterior pituitary. So if we have any disease in the hypothalamus or the posterior pituitary, it might lead to loss of the ADH, and finally the kidney is not able to conserve free water in response to serum hyperosmolarity. Actually, for this heading, for colleagues who are doing a lot of neurologic and neurosurgical cases, especially in pituitary and hypothalamic tumors, we almost in 100% of such patients, we found such patients are going to diabetes insipidus, which might be temporary, and sometimes it's permanent. So it needs attention by taking into account the water balance and frequent monitoring of sodium in such cases. Sodium gain, actually, this is not as common as the disturbances we mentioned before. As I mentioned previously, that the administration of hypertonic solutions like sodium chloride and hypertonic saline, some cases of salt poisoning, which might be suicidal in some cases or accidental in other cases. In patients who are feeding, in taking hypertonic feeding solutions, also there is sodium load if we are not taking about an equal amount of free water that has to be replaced in such cases to counteract the osmotic load created by hypertonic feeding solutions. Now, we'll talk about again the hypernatremia. It's a disturbed relation between the total body sodium and total body water, but finally there is usually, in most cases, there is a net water deficit, but it happens that this net water deficit occurs in conditions of low total body sodium and normal total body sodium or increased total body sodium. From this, we can go to the differential diagnosis of the underlying condition beyond the hypernatremia. So if we have hypernatremia with low total body sodium, what is the reasons of hypernatremia with low total body sodium? This might occur when we have renal losses. We mentioned before that if you are using loop diuretics or osmotic diuretics, So there is loss of both sodium and water, but the water loss is in excess of sodium. So the patient goes to net water deficit and consequently hypernatremia. And in addition to what we mentioned before about the loop diuretics and osmotic diuretics, let's remember one of the common cases that we face frequently, patients with either diabetic ketoacidosis or hyperglycemic non-ketotic coma, where we have a high glucose, serum glucose concentration leading to osmotic diuresis. It acts exactly as mannitol acts. In such cases, how can we differentiate it? When we measure the urine sodium, we'll find that the urine sodium is more than 20 millimole per liter because there is loss of sodium as well as water in such cases. And the second reason for low total body sodium hypernatremia with low total body sodium is extrarenal losses, like excessive sweating. And in such cases, we'll find the urine sodium less than 10 millimole per liter because such patients get as well hypovolemia. So the kidney is trying to conserve as much sodium as it can, so it can improve the volume status in addition to the osmotic status. So the second type of hypernatremia is hypernatremia with normal total body sodium. So the total body sodium is not affected in such cases, which means that the disorder is mainly a disorder of free water deficit. The renal causes for this is clearly the diabetes insipidus, because diabetes insipidus, it's a disorder leading to free water loss and free water deficit. This in case the renal, the kidney is the cause of this disorder, or it might be due to extra renal causes like respiratory and insensible losses. And in these two conditions, normal total body sodium, the urine sodium is variable. We cannot rely upon in such cases for differentiation between whether it is renal or extra-renal. In cases of hypernatremia with increased total body sodium, this occurs either iatrogenic, we are using a big amount of sodium loads from outside, like sodium chloride or hypertonic saline, for example. And in the two endocrinal condition, Cohen's syndrome, which is primarily mineralocorticoid excess disorder, and Cushing's syndrome, which is primarily glucocorticoid excess disorder. And we know that mineralocorticoids and glucocorticoids finally leads to retention of sodium by the kidney. And in such cases, we'll find that the sodium is more than sodium in urine is more than 20 millimole per liter. Now let's talk about diabetes insipidus, because it constitutes a significant amount of hypernatremic cases we face. What is diabetes insipidus? As we mentioned briefly before, that the diabetes insipidus is loss of free water by the kidney. So loss of free water by the kidney is either due to lack of the agent, which leads to reabsorption of free water by the collecting duct of the kidney, which is antidiuretic hormone. In such case, it's called central diabetes insipidus. Or it is lack of response of the kidney due to resistance of the renal tubules to antidiuretic hormone. And in such cases, it is called nephrogenic diabetes insipidus. We mentioned some of the causes of central diabetes insipidus. In nephrogenic diabetes insipidus, actually it occurs in certain electrolyte disorders like hypokalemia, hypomagnesemia, and usually in such cases it's temporary, so it resolves after correction of the underlying electrolyte balance. It is caused by some medications as well. The most famous medication which causes nephrogenic diabetes insipidus is lithium. There is a transient third cause of diabetes insipidus, which is called gestational diabetes insipidus. It occurs in some pregnant patients in the second trimester due to excessive secretion of vasopressinase from the placenta, and this vasopressinase breaks down the serum antidiuretic hormone, leading to diabetes insipidus, and this type usually resolves. I mean, it's not very common, but it happens. It resolves in the third trimester, and usually it's transient in such cases. This is diabetes insipidus. So if we would like to differentiate between the two common types of diabetes insipidus, which is either central diabetes insipidus or nephrogenic diabetes insipidus, we'll find that they are almost similar in many criteria, like urine output. Usually it's very profuse urine output. It's more than 3 liters per day. Sometimes it reaches up to 10 liters, 15 liters per day. And the plasma osmolarity, usually it's more than 300 milliosmol per kg in both types. And of course, it might go higher, too much higher than this if there is limited supply of water. For the urine osmolarity, usually it's a dilute urine because the kidney is losing free water, leading to reduced serum osmolarity. So they are similar in this also. Specific gravity, it's low for both conditions, but here is the difference. If we are going to measure the plasma antidiuretic hormone in central diabetes insipidus, we'll find it low, and this is underlying pathophysiology actually. And in nephrogenic diabetes insipidus, it's high because there is increased osmolarity, stimulating the hypothalamus to excrete ADH, but the kidney is not responding. So the level is high, and the important differentiating factor as well is the response of the urine osmolarity to ADH administration. For central diabetes insipidus, if you are going to use external antidiuretic hormone, so the disorder is resolved, so the kidney responds, and it conserves free water, leading to increased urine osmolarity. But if we are using the same drug in nephrogenic diabetes insipidus, so the kidney is not responding, so we don't observe any response of the administration of the medication on the plasma, on the urine osmolarity. So what are the clinical manifestations of hypernatremia? Of course, it depends on the level of serum sodium. If we are in the range of 155, there is thirst. If the thirst mechanism is active, there is restlessness, there is irritability. When it goes up to 160, there is muscle weakness, there is lethargy, and there is confusion. And if it exceeds 160, there is seizures, coma, and death. Here, I think we mentioned before in hyponatremia that the problem, I mean the neurological problems, related to disturbance in sodium, whether hyponatremia or hypernatremia, it's related to water shift either from the extracellular department to from the extracellular compartment to intracellular compartment in cases of hyponatremia, and the opposite in hypernatremia, there is shift of water from the intracellular compartment to extracellular compartment. In both conditions, it disturbs the cellular homeostasis, and the most important cells which leads to symptoms and signs in such cases is the brain cells. It is going to be swollen in cases of hyponatremia. It is going to be shrunken in hypernatremia. So there is disturbed homeostasis of the cells leading to these neurologic abnormalities. And we have to remember that most of the symptoms and signs of sodium disorders are neurologic. So when we face a patient with hypernatremia, whether we are facing this patient in the emergency department or in the ward or in the ICU, we have to look carefully on the clinical background of such patients, starting with the history and physical examination. So from the history and physical examination, we would like to give attention to the fluid status. And we have to remember, usually there is an underlying comorbid conditions when we have serum sodium disorders. We have to review the medications as mentioned here in regarding hypernatremia. There is a lot of medications which causes sodium disorders like osmotic diuretics, loop diuretics, excessive mineralocorticoid use or excessive glucocorticoid use, lithium, for example. We have to monitor to get the laboratory findings. Of course, the most important is the electrolyte panel, which shows serum sodium more than 145. And whenever we get serum sodium, we have to get the serum osmolarity as well. Also, we need to measure the urine osmolarity and urine sodium because, as mentioned before, it can help in the differential diagnosis. Okay, then we come to the management. There is a general rules for the management of hypernatremia. We have to replace the fluid, and replacement of the fluid, it depends on the underlying condition. If we are taking, for example, the patient who are losing water and sodium, but water in excess of sodium, like in cases of osmotic diuresis or excessive loop diuretics, we just need to replace both sodium and water, but the fluid we are using usually takes into account this pathophysiology, so it should contain more water than the sodium. For example, if we are correcting the hypovolemia and hypovolemic patients with 0.9% sodium chloride or lactated Ringer solutions, for example, which contain an amount of sodium between like 140 to 150, we are going to use a half concentration of sodium chloride, like 0.45% sodium chloride. And if the disorder is mainly a water balance disorder or a water deficit disorder, like patient with diabetes insipidus, in such cases, we have to replace free water. And for replacement of free water, we have two options: either to let the subject or the patient drink water if the patient is able to drink, If the patient is not able to drink, we are going to use this water through the nasogastric tube. And if the gastrointestinal system is not functional, we might use intravenous water. We cannot use, of course, intravenous water, but we consider dextrose 5% as an essential water fluid, so we can use the 5% dextrose in such cases. Just considering in cases of big amount of free water deficit replaced by dextrose 5%, we have just to take care of the hyperglycemia, which might face and to be corrected by use of insulin as well. About the rate of correction, it's actually, I mean, the rate of correction, it's an extrapolation from the guidelines from of hyponatremia. As mentioned before, that if we are correcting hyponatremia, we have to stick to the range of 8 to 12 milli equivalent per day and about 0.5 milli equivalent per hour. Despite there is some evidence in hypernatremic patients that rapid collection doesn't cause the demyelinating disorder, which is more common in cases of hyponatremia with rapid correction. Of course, if we are correcting the hyponatremia, just to stick to the recommended range, we have to regularly monitor the serum sodium, and depending on the rate we would like to correct, we have to adjust fluid therapy based on the patient response. For example, if I'm using water, for example, either through the gastrointestinal system or through the use of dextrose 5%, and there is an overshoot of correction, I might stop this and I might use some sort of isotonic fluids to delay the rate of correction. And the same applies if we are going to a delayed rise or delayed correction of sodium. And we have to take care always when we are dealing with sodium balance that usually there is an underlying pathology. So we are correcting the sodium balance, but we have to look for the underlying pathology. There is no hyponatremia or hypernatremia unless we have an underlying pathology. So how can we calculate the amount of free water that we have to give the patient with hypernatremia to restore the sodium balance to normal? Actually, this formula calculates the free water deficit. Actually, I was using this formula before because we go deeply into the internet and the new mobile applications now, but there is a lot of mobile applications now which contains all calculators in medicine. For example, I use Medscape application for whatever calculation I need. So I just go to the free water deficit calculator in Medscape and calculate. For calculation, actually, we need the body weight and the sex of the patient, because based on the body weight, as we mentioned previously, the male is 60% water and female is 50% water. So from the age and sex, the weight and sex, we can calculate the total body water. And we need to know the current sodium relative to the normal sodium, which is 140. And from this equation, we can calculate the free water deficit, which can restore sodium back to normal. And then we start our correction, whether it is acute so we can correct in a faster range, or it is chronic that we have to go for slower correction with the range we mentioned previously. So the rate of correction, I mean, if it is hyperacute, I mean, if it's developed less than 24 hours, and we can see this a lot in patient with post-pituitary surgery. Usually the patient, after coming back from the theater to the ICU, they develop diabetes insipidus, and there is a huge amount of urine. It's essentially free water. So if this is not corrected, so the sodium rises steeply in less than 24 hours. So if we are going to correct this, we might go for correction in less than, I mean, we can go for rapid correction in such cases because it's hyperacute. If it's chronic hypernatremia, which developed more than 24 hours, or we don't know the time of onset, so we stick to the range as mentioned previously from 8 to 12. If there is this hypernatremia is accompanied by hypovolemia, and example of this is diabetic ketoacidosis and hyperglycemic non-ketotic coma. Usually such patients come with hypovolemia because of excessive loss of both sodium and water, but water too much in excess of sodium, so they come hypernatremic and hypokalemic and hypernatremic as well. So in such cases, the restoration of volume usually takes precedence over sodium correction unless the hypernatremia is symptomatic. So we go to restoring the circulating volume with lactated ringer. And if during restoring of this sodium, the chloride is high, we might switch to a solution with lower chloride content, like 0.45% saline, or for some time with dextrose water. And after restoring the volume, then we go up to the, according to the rules for correction of hypernatremia. And most of such cases, usually the hypernatremia improves with restoring the circulating blood volume. So if we have the type of hypernatremia with normal total body water, which is essentially, it's a free water loss. As I mentioned before, that we are going to replace this free water either intral or intravenous. Intral by water through the gastrointestinal system, either the patient is able to drink, so we'll let the patient drink water, or if not able to drink, we are going to supply this water through the nasogastric tube. Intravenous means that we are going to correct it with 5% dextrose. In addition to correction of free water deficit, if the underlying pathophysiology is diabetes insipidus, we need to replace, if it's central diabetes insipidus with deficiency of antidiuretic hormone, we need to replace the antidiuretic hormone by an exogenous agent. And there is an agent called desmopressin, which is a synthetic analog of antidiuretic hormone. This agent can be used transnasally through the nasal bath, or it can be used intravenously. It's available in both forms. We can use it for replacement therapy for patients with central diabetes insipidus. If it's complete, if it's partial, sometimes it's partial, it's not complete. So we might use also desmopressin, but in such cases, sometimes chlorbromamide and carbamazepine may be effective in partial central diabetes insipidus. If it's the cause is nephrogenic diabetes insipidus, we are going to use low salt diet, and thiazide diuretics usually improve the nephrogenic diabetes insipidus, but we should not forget to look for the underlying condition causing nephrogenic diabetes insipidus, like if the patient is hypokalemic, hypomagnesic, or using one of the medications which causes nephrogenic diabetes insipidus. This is for the type of nephrogenic diabetes insipidus which is caused by certain agents and not the congenital. If you are dealing with a type of hypernatremia with low total body sodium, which is loss of sodium, but loss of proportionately greater amount of water. The classic examples are osmotic diuretics, whether it is hyperglycemia or use of mannitol, for example. So if it's related to hyperglycemia, we are going to deal with hyperglycemia according to the type of hyperglycemia, whether it is iatrogenic hyperglycemia or it is diabetic ketoacidosis or non-ketotic hyperglycemic coma. And we have to consider use of normal saline for correction of sodium, whether it is 0.9 or 0.45%, depending on the level of sodium and the level of chloride in such patients. If you are dealing with the type of hypernatremia with increased total body water, which in most cases are iatrogenic, so for example, if the patient is transfused with a big amount of sodium bicarb, for example, so we need to stop the offending agent, and we are going to use 5% dextrose to replace, to increase the total body water to neutralize the high osmotic load of sodium, and add furosemide, because whenever there is a high load of sodium, of course, the intravascular volume is going to be expanded as well. And even when we add water or dextrose 5%, the expansion is going to increase. So the priority in such cases is to treat hypernatremia, and then we can treat the hypervolemic state, which is going to happen by adding furosemide or any loop diuretic. So the complications of hypernatremia, it's related actually to the pathophysiology, or it's related to either shrinking of brain cells in cases of hypernatremia, or swelling of the brain cells in cases of rapid correction of hypernatremia. So patient might get cerebral edema in case of rapid correction. The patient might get seizures and coma in both cases, either in hypernatremia itself or the rapid correction of hypernatremia. And it might exacerbate or even induce a new kidney injury. And also, this is very common if you are using mannitol, for example, excessive mannitol use while you are not caring too much for the fluid and water balance. The patient gets hypernatremia, and if it's neglected, we'll find that the kidney profile is rising as well from the normal range, or even if the patient has a chronic kidney disease, the patient goes into acute kidney injury on top of chronic kidney disease in such cases. And actually, in the hospital setting, actually, it's preventable. It's preventable in the sense that we have to monitor our patient regularly. We have to link our management to the underlying medical condition of the patient. And in potentially prone patients to hypernatremia, we have to go for frequent electrolyte monitoring in such cases, and whether they are patients in the wards. And of course, we need more frequent monitoring in critically ill patients because they have a lot of underlying conditions. They are very prone to iatrogenic hypernatremia as well. we have to tailor our fluid management based on the patient underlying condition and based on the monitoring of patient electrolytes. We have to calculate very well the fluid input and output. Of course, if we are dealing with ambulant patient, we have to educate the patients at risk or their companions, like old elderly patients with low thirst sensation, or the mothers caring for infants. And we have to teach them how to discover from signs and symptoms that this patient might be hyponatremic, so they can seek medical advice. So finally, hypernatremia is a potentially life-threatening condition. It is common in hospitalized patients. Of course, we have to be careful about accurate diagnosis, monitoring, and correction based on the guidelines, whether it is acute or chronic. We have to look for the underlying causes whenever we have hypernatremia. It's not just we are correcting the number. We have to look for what is the reason why this patient got hypernatremia, because we might discover that the patient have a serious underlying condition that can be managed as well. Thank you. شكرا جزيلا.